you have elevated CRP and hypogammaglobulinemia, I think you should think, could it be a genetic disease? And then you have to perform the genealogic tree, look for some other clues, and discuss, but it's very rentable. It's not so frequent to have hypogammaglobulinemia and chronically elevated CRP, and so you have to discuss, but I think it's very worth it, especially if you have AF2s or if you have any livedo. So I think it belongs to the red flag. And it's very cheap to do it. Another thing, I don't know if you have access to this, but ADA2 deficiency, it's an enzymatic problem. So we can now measure it, ADA2 activity. So we can measure it easily in France, but there's an American called Michael Hersfield. He's measuring it for free everywhere in the world. You just have to put it on Buva, I know how to call that, and you send him by the post, so it only will cost you a stamp, and then he will answer you the dosage, and you can suspect the disease. That they measure ADA2 deficiency?
Yes.
Oh, so with that, you can then go ahead. So now for the 20 more minutes, I will speak to you about monogenic autoinflammatory disease. So as I told you in the introduction, it's a disorder of innate immunity. And what is hard is when should I think about them compared to all the classical inflammatory diseases, because they are not so frequent, of course. So when we make a zoom on those diseases, we have the monogenic I told you about. We have the one with the criteria, set of criteria, such as Still disease or Schneider disease with the gammopathy. And this is not well translated, but it's the unclassified autoinflammatory disease. So I will speak very quickly, only 2-3 minutes on the history, because I've already told to you about, but the 4 historical are here. In the introduction, I told to you about these 2, and in the cases, I told to you about CAPS. They were described 25 years ago now, but now I updated this about 4 months ago. We have so many, and it's very hard to know all about them, especially even if you are a specialist. Sometimes only the genetic will tell you what it is. So as there are a lot of them, I want to tell you how do you do when you suspect this? You'll say, oh, could this be behind this picture? Maybe there's an autoinflammatory disease. So for example, who do you think is behind this picture? Can you tell me, can you help me to find someone to answer? Who has an idea? Say very high. Ken Middleton. Yes. Who is behind this picture? They are good. So yeah, that's so it can be tricky because look, they kind of look like each other. So it can be very hard. So that's why you have to always keep some ideas and clues. So fever is important, but sometimes fever is not there. So you have to look for elevated CRP. It's a good clue because we used to say there are 4 historical recurrent fever, but actually, I tell you, only FMF and TRAPS in adulthood have a lot of fever. The other ones, in CAPS, you have almost never fever in adult. And in MKD, it's not so frequent. So when we are an adult, we have to check for CRP. So what is important is it has to start more than 6 months ago for adults, except for Still disease. But I'm not speaking of Still disease today. You have to have recurrent attacks. Fever is very good if you have it, but sometimes it's lacking. And then the fever is not naked. So you have the skin. I showed you some AF2, some urticaria. You have the musculoskeletal system, and you are all experts. And we have some digestive tract manifestation. And you have really to look for inflammatory in a crisis. And then the negative feature, as always, no infection, no neoplasia, almost no antibody, almost no immune deficiency. I will stay simple today, so let's stay almost. In very specific case, we can have some. So the timeline is important. We are all adults in the room, I guess, so we have to say at least 6 months. I put this star for Still disease, but to evocate, you have to have at least 6 months. But of course, it's very much easier when it has begun in childhood, as I showed you in the 3 previous cases. The fever is important, but don't forget it can be absent. And it's important to know how long the fever is. In FMF, it's short, and in TRAPS, it's long. The second option is that you can have fever, but you can also have chronic inflammation. And it was the case in all the clinical cases I showed you, they had chronic inflammation. Digestive tract, it can be pain, or it can be diarrhea. It's mostly pain. The skin and the mucus are very important. So you have to ask for aphthous, and you have to look everything in the skin, and you have to ask the patient to take pictures and send them to you or to show you in consultation. Sometimes they arrive with a UB key and they show me like 20 pictures of all the eruptions, etc. So it's very helpful. Then all the musculoskeletal, it can be myalgia, it can be arthralgia, it can be arthritis. And also it can be, I don't know what the patient has. So what should I do when this happens? It can also be, I tried all the treatment I know, but nothing worked. So that's what happened in this man with the periarteritis nodosa. He had cyclophosphamide, he had methotrexate, he had steroids, etc. Nothing worked. So it means you missed your target because you thought it was a classical autoimmune disease. Then the familial transmission, I hope I convinced you by the last cases that it's very important to perform a genealogic tree looking for a familial transmission. Here it's a dominant transmission, look, because every generation has somebody who is sick. And also, I will not speak more about this after, you can have AA amyloidosis, like this DALA2 patient. So nephrologists can send you the patient to say, well, I found AA amyloidosis, but I don't know what's the disease responsible for inflammation. So who are the cells involved? The innate immune cells, there are macrophages, monocytes, neutrophils, and a little bit mast cell. So these cells, they sense all the danger, and they induce the secretion of pro-inflammatory cytokine, especially IL-1, IL-6, IL-18, TNF-alpha. So I made a little drawing for the youngest. So you imagine one immune cell, like a monocyte, macrophage. So there's a danger coming, and the cell, her job is to look for danger and transmit the information to the cell. So the sensor can detect the danger, and also the adaptator can give the information to the nucleus. So you can have mutations in the sensor, in the adaptator, and also you can give many types of inflammation, especially IL-1, I told you about, and IL-6. That's the reason why we have so many different pathways for autoinflammatory disease. So I told to you about CAPS and FMF. I will talk a little bit after of NF-kappa B disease because those are the two most frequent. And I will not speak a lot about ADA2 deficiency because it's not so explained. We don't really understand well the pathophysiology. And I decided today not to speak about those because they are quite rare and I didn't have a lot of time. So the three main pathways I will speak about are the IL-1 pathway, NF-kappa B pathway. And I told you I will not speak a lot about this one. So in the interleukin-1 pathway, the two main inflammasome is the pyrine, which is mutated in familial Mediterranean fever, and NLRP3, it's mutated in cryopyrinopathy. So I told you two families with NLRP3 mutation. So it's the main diseases, and they are the most frequent autoinflammatory disease, especially FMF. And I will speak a little bit about NF-kappa B because in F-kappa B pathway, we have a lot of aphthous. And so it's the one that our colleague can suspect when you have bipolar aphthous, and it looks like Behçet. So the genetic testing, I spoke yesterday with Filipa, and she told me you had a lot of access to genetic here in Portugal. So I will be quite quick, but just a few definitions. What we call next generation sequencing in 2024, it can be panel, it can be exome, and it can be genome. So there, we just exclude the classical Sanger sequencing. The Sanger sequencing is important in FMF because you only sequence one exome. And in FMF, most of the mutations are in the exome number 10. So you can ask for Sanger because it's kind of cheap. In France, it's less than 100 euro. I don't know how much it is here. And it's quite rapid. And it's not time consuming for the geneticians. So that's what we do for MFV. And then all the other ones, we always ask, what could be the best exam for my patient? Should I ask for a panel or an exome or even a genome? So the panel is useful when you look for a somatic mutation. Why? It's because you have a library of genes that you put there. So she told me that you have 400 genes in your panel, including all the primary immune deficiency and autoinflammatory disease. So I think it's a very good panel to have so many genes. And then you will look for mutations. You will also be able to detect somatic mutations, which are affecting a small amount of cells, for example, between 2 to 10% of cells. So that's a good way. And it's a parallel approach compared to single sequencing. And I don't know if you have this, but we have a program in France now for genome sequencing by the ministry. So it's free for the selected patients. And it will probably be a very useful way to diagnose new diseases because you have all exons and intro and all genes. So the single sequencing is very targeted sequencing, and I think it's good for FMF, or if you have already identified a mutation in a family and you have a new member and you want to confirm it, then the panel, it's useful for when you don't really know which one, or when you are suspecting a somatic mutation, and all the other ones, the exon is useful to sequence all exons, and the genome I just told you about. It's like the whole tree with exon and intros. So in 2024, I told you single is when you know the family, the somatic mutation, you should ask for panel, especially if you suspect a CAPS. And we think that then West should be the first intention in trio if possible, and if negative, consider genome sequencing. So I will speak a little bit about FMF because it's the most frequent one. So in FMF, you have a mutation in the pyrine, and it will induce an excess of IL-1. So FMF, I showed you in the film, is more frequent in Mediterranean countries. And 95% of patients have abdominal pain. Some of them don't have fever, but they all have abdominal pain in most cases. The pathognomonic feature of FMF is pseudoerysipelas. So I don't know if some of you, maybe you can raise your hand if you have already seen pseudoerysipelas. Philippa. So I wanted you to see this picture because if you have seen it once, you may not forget about it. And it's very useful because I don't know any more disease with pseudoerysipelas. So they have abdominal pain, fever, and in rheumatology, they can have arthralgia of the large joints, myalgia. And one specific thing in rheumatology is the coccytis. So elderly can have destroyed their coxofemoral articulation and require prosthesis. So I wanted to show this because I have several adults with prosthesis because of coccytis. Also, for all of you, if you have a patient with arthritis and who had been operated for nothing on the belly and many scars, you can suspect FMF, and it's what happens also in Armenian and people originating from North Africa. Another feature is a patient with arthritis and episode of tamponade. So pericarditis can be revelating of FMF. Also hepatomegaly, like the lady I showed you in CAPS because of chronic inflammation. And then AA amyloidosis, the most frequent cause of AA amyloidosis if you suspect a monogenic disease is FMF because FMF is the most frequent monogenic autoinflammatory disease. So this is one of my patients with nephrotic syndrome. The duration is very short, 2 to 4 days, and usually it can be sporadic. And I already told you about the black pestis, but I just wanted again to say it because when you have a patient, usually they are like so annoyed, I have this disease, I am so annoyed. And I say, yes, but you are also, you have a positive fact is that if we have again an epidemic, a pandemic of pestis, you will survive and I will die. So sometimes when you have a very pessimistic patient, it helps him to feel like he's kind of X-Men, you know? Yes. Yeah, the adolescent, I tell them, and when they get out, they say, oh, I'm kind of an X-Men. So that I think that's an important thing. So for the CAPS patients, I've already showed you many pictures, but I'm sure there are more and more CAPS and people don't know they have CAPS. So as we have a very effective treatment in FMF and CAPS, I think we should diagnose more patients. So there are more than 30 cases worldwide. I'm sure there are more than 1,000 cases. I showed you a lot of pictures of urticaria. I will show you some more. This is, remember the one I showed you, the lady. And this is some picture I've already shown you. It's cold induced. It means that if you have cold in the room, it can induce the crisis. It's not if you put an ice cube on the arm, okay? It's atmospheric cold. So this is another family. Look at the lesions. This is in consultation. She has no treatment. It's not a crisis here. And with the crisis, that's what happened. This is all a real picture that they sent me. So this is in my box. And this is at home when she has cold. This one, you've already showed it. So this is the one I told you she had seronegative arthritis. She was one of the aunt of the case I showed you. So she had this. And she also had this finger. This one, you showed it. So please think about CAPS when you have unexplained neuroinflammation, deafness, uveitis. Even though you don't have urticaria, you can suspect CAPS and you have to ask for a panel. So this is another family. Look at the dominant transmission. It was a very large CAPS family. And I decided to speak very little about traps because I will ask you, how many traps do you have in Portugal?
In our registry, we have 5.
It's very rare. Even in my center, I'm totally dedicated to those diseases. I just diagnose maybe 1 traps every 2 years. So it's very rare. So I will not speak a lot about traps, but as you are all rheumatologists, in traps, you have abdominal pain and myalgia, very intense myalgia. Okay, so that's very important. Fever, abdominal pain, and myalgia. The other ones are not so frequent. And the duration of the fever is quite long. This is some very specific dermatologic features of, so MKD. How many MKD do you have in Portugal?
Not sure about the national registry, but here in our center we have 3.
So very rare. So again, I make 1 diagnosis every 2 years, so it's very rare. So I will not speak a lot about this because traps and MKD, usually it's the genetic that gives the diagnosis in adulthood because it's impossible to guess the disease before. So in MKD, there's a lot of abdominal involvement. Articular involvement is not very frequent except in childhood. And I will go through this. I show you they have adenopathy, they have aphthous, again, aphthous, and they have acne. Okay, so that's it. So what is tricky in those diseases? So I chose only a few tricky things to tell you to be simple. So now I'm sure you know about the 4 hereditary recurrent fever. FMF I put bigger because it's the most frequent one. CAPS, I hope now you are convinced that you have to do more diagnosis. And the other ones are very rare. So what is tricky in FMF? And this is a very, very new slide that I performed last month. Before we thought FMF, it's only exon 10 mutation, the classical FMF with all the people originating from Mediterranean. But it's not anymore true. So I just wanted to show you with a few slides. It's not so true. So all the years are down, and here is all the countries that reported mutations in other exons. So the exon 10 is the one I showed you that you have to sequence by Sanger and the classical FMF. So people found mutation in exon 5, exon 8, exon 2 in many, many different countries. So by seeing all those flags, you can see it's not so Mediterranean. And also one very interesting thing, we recently found a somatic mutation also in MFV in a French lady. So it's more cosmopolitan nowadays and it's mostly dominant. So now we say there is the classical FMF, but we also have other pyrine-associated autoinflammatory disease that are not called FMF, but they are mutations in MFV gene. And they are mostly dominant. So that's another information. So the genetic is always there to tell you what it is, but you cannot guess without the genetic. But very important to perform the genealogic tree to look for a dominant transmission. So those diseases, I will not say more. Now we'll say about CAPS. I showed you a clinical case of these Portuguese ladies without urticaria. And when I began to work in this field 12 years ago, I couldn't imagine a CAPS without urticaria. But in the last year, I diagnosed 20 patients without urticaria because of a mutation in a new domain, which is the LR domain. It's not the classical domain, and it's the one that was mutated in this Portuguese family I showed you with the deafness and without urticaria. So again, the second message here is like the last one. Then the genetic will tell you what it is. It's quite impossible to guess before. So this was our last publication on the LR domain, and you can see that we had a collaboration with Raquel Faria in Porto in this European work. And some other people published on this, and I will go for more. So some other teams published on CAPS mutations with hearing loss and without urticaria. So we are not alone. So I'm finished with this. And somatic mutation, it's very important because you can have CAPS in a sporadic patient because of somatic mutation, and it will not be a dominant transmission. So somatic mutation, it means that only a few cells are mutated. It's like a mosaic. And this is one of the only slides I will show you, but for one gene, this is the NLRP3 gene. You recognize the LR domain because I told you about. You can have here mosaic mutation and germline mutation. So it's complicated. So I told you about mutations, somatic mutation in CAPS, in TRAPS, there are some in FMF, and maybe we'll find somatic mutation in other classical monogenic autoinflammatory disease. So for TADA2, I will only show you one slide because I told you about this case of this man, and I showed only one slide. You can find some very good review in literature. The problem of ADA2 deficiency is the strokes. And the NIH published that if you give TNF inhibitors, you can prevent the occurrence of strokes in families with strokes. So I think it's very important to diagnose them because you can give them TNF inhibitors and then you can prevent strokes. So I think it's a very important message to diagnose. I will speak a few minutes on FKBP because there's so much to say. So it's mutations in all downstream the TNF receptor. So A20, we were speaking about it, it's a dominant disease, and the number of patients is increasing. We have about more than 180 published nowadays, and I'm sure there are more than 200 because not all of them are published. And the description of the disease was in 2015. So it's a cosmopolitan disease. Every country can have HA20 deficiency. There's a pediatric onset, so look at this, very important. If you suspect HA20 haploinsufficiency, you have to ask for the beginning of the symptoms, and it's usually before 10 years old. The clinical features, so this is a picture, but I encourage you to read the slide after because we made recently a nice review. The oral aphthosis is frequent, but also the genital aphthosis and abdominal pain. So when could we suspect HA20? It's non-isolated oral or bipolar aphthosis. CRP is elevated all the time, the childhood onset, and in most of 60% cases, it's a dominant disease, and there's a lot of abdominal pain. So we have a very nice review, and I could send to Philippa the PDF of this review, and it will give you all the data and all the main presentation of the disease. Genetics is very important because in front of bipolar aphthosis, you cannot guess the disease. We have to go to genetics. Then I will finish with VEXAS syndrome because it's a very interesting disease. So before the discovery of VEXAS syndrome, that's the way I would see the elderly patients with inflammatory disease, and we didn't know what it was. So they were like kind of looking like each other, but all of them were different. That's the reason why I put different picto and different colors. And we tried to put them in some groups that look similar. But then came out this paper, and I don't know you, maybe I'm crazy, but when I saw this paper, it was on Twitter, quarter before midnight. I was in my living room, and I was like, oh, this is incredible. And I thought of so many patients, and then you will see after, that's the reason why in France, we thought about so many patients, and we couldn't diagnose till nowadays more than 300 of those VEXAS because we knew all the symptoms and we knew the patients that we couldn't have classified before. So this syndrome was described by David Beck, and it's a UBA1 mutation It's a somatic mutation. And the acronym stands for V for vacuole, because the myeloid progenitors are vacuole. E1, because there's a UBA1 is a mutation type E1 of the ubiquitin pathway. X, because it's on the X chromosome, so it's X-linked, and it's an autoinflammatory somatic disease. So it's an acquired mutation on the X chromosome. In the first paper, they said that the youngest Vexas was 46 years old, but actually, the youngest published is 23 years old. He's from Mexico. The demography, this is actually reported more than 300 worldwide, but I tell you, even in France, we already have 300. So I'm sure there are more than 1,000 worldwide. It's cosmopolitan. Every country has. I know in Portugal, there's a series of 7 at least published cases by Raquel Faria and her team. And the average age is 67 years, and 95% of them are male. So some women can have Vexas. So you must not inhibit yourself of suspecting a VECTAM in a woman, because women can have X monosomy. So if they have X monosomy, the active X will, if he's mutated, he will express the disease. So we actually have an international consortium on Vexas, and we identified 14 women worldwide, and in France, it represents about 5% of our cohort. So as we are about more than 50 years old, how should I recognize a Vexas? So who do you think is hidden behind this picture? Oh, they are good. So then I said, because I didn't know him before, so I checked on Google, and I thought, well, it makes me think about someone else. So who do you see behind this? Do you know who it is? I hope you know him. I'm sure you do. No, nobody has any ideas? Let your imagination go. So it's Peter Falk. Colombo. You don't know him? Inspector Colombo. So at first I said, so I really like Colombo. And look, I took off the cigar because I didn't know if you were a smoker. So I think it's important because in front of a patient, you are asked to say, well, should I suspect another disease? Which one? So it's always blurry when you have the patient in front of you. You have to think, what are the clues? How can it look like something? So how can Juan look like Colombo? So how can my patient look like a Vexas? So this is my old Vexas man picture. So they are always very tired, and usually they have a weight of loss. And very importantly, they have macrocytic anemia and CRP. So I have to stop because it's 10 o'clock. So I will just tell you the few messages. CRP is permanently elevated very high with elevated VGM. Here is the vacuole in the myeloid progenitors. And I wanted to show you a few pictures of the skin because skin is very informative. Look at this. The lesions here are very pathognomonic of the disease. Look at this one. If you remember this one, you will make Vexas diagnosis, or the young here. Look at this, it's very prototypic. So there are a lot of papers now on skin involvement. It's maculopapule on the troncula, but everywhere. They can also have livedo and pustule. Look at this one. It's very specific. And there's a last one picture I wanted to show you after. Look at this elderly man with the chondritis and all the specific maculopapullar lesion. And look here, he also has edema of the eye. So he has almost all the features. So if you have an elderly patient with arthritis in your bed and elevated CRP and the volume of the red blood, you can suspect Vexas. They also have lung involvement. And I just wanted also to show you the eyes. This is a prototypic picture, but some of them have a little bit less like this. And it's, I don't know any more disease with this. So it's a very specific feature of Vexas. Chondritis, I'm sure you are very useful, so I will not develop. There is no phenotype-genotype correlation. And this is the picture when I stopped at one time the French database. And you can see the skin lesion is very important. Fever, weight loss, infiltrate, and ocular involvement. Polychondritis is only in 1/3 of cases, and all of them at macrocytic anemia and CRP elevation. So maybe some of you will come to our first international Vexus next month, and Portugal will be represented. And so to finish, I already showed you this slide, so I will go on. And my conclusion is there FMF in Portuguese people? We spoke yesterday evening about this. And I will say not if they are totally Portuguese origin, if they have ancestries from Arabic or Turkey maybe, but not if they are really, because Mediterranean is not touching Portugal. And I hope you like this one, and you will not forget to always look for a Vexus behind another man. I hope you also like this one, because always look for a monogenic disease when you have elevated CRP. And this last quiz for you is one of my best quiz. So who is hidden behind? I give you an advice. At home, I have 3 men at home. So when I work, I always have football. So the importance of genetic sequencing even in adults, think of CAPS even without urticaria, and the treatment change the patient's life and prevents amyloidosis and deafness. And I thank you for your attention. So sorry I was long. Do you have one or two questions?
Inflammatory disease without CRP, is it possible? Can we exclude automatically non-inflammatory disease?
You will exclude all the inflammation or NF-kappa-B, but you can maybe suspect an interferonopathy. So it will depend if the clinical picture is very evocative of interferonopathy. Possible. It's possible, but I will say especially in pediatry and in adulthood, it will be less likely. So I will advise you to seek more in inflammatory patients. It will be more rentable.
And Sophie, what is, as we talked yesterday, of course, the main diagnosis in our autoinflammatory clinic is undefined autoinflammatory disease, because we perform the genetic testing and we just have like variants of uncertain significance and come to any diagnosis. So what do you do next in these cases?
So I don't know if I should answer because it can be long. And we had, an ERN web emission on this, but to what do we do now in 2024? If we really suspect with an important tree and we have a familial history, of course, we will go to genetic testing. And if we trust, we will go to the genome sequencing. And sometimes it's negative and we'll say, maybe in the future, we'll find a gene, if it's a familial history. If it's a sporadic case, it's always harder. So when we have inflammation, we have 2 tools that are very interesting, is the interferon signature. I think you spoke about this with Alexander below. So it advises to put JAK inhibitors and to guide targeted treatment. And then we now perform IL-18 because of the interest of IL-1 inhibitors in IL-18, and also because I didn't speak about them, but we have now IL-18 genetic disease. And if we suspect and have elevated IL-18, we will look for those genes in the sequencing. So if everything fits with an autoinflammatory disease and you have eliminated all the infections and hemoplasma lavana, we'll say it's an undifferentiated. We will try to improve the treatment and see if it's more an IL-1 disease or an interferonopathy disease. And we will put a little bit more IL-1 inhibitors or JAK inhibitors. And then if it doesn't work, we will try IL-6 inhibitors and IL-10F inhibitors. And that's it. Yeah.
Regarding the attitude again, so we test the family members into which generation? The fathers, mothers, or they go further? And second question, if any of them test positive, you always treat them with an DNA.
So those are very good questions. I will answer quickly, but you can find, or I can send Philippa the PDF of the international recommendation for that too, that were we published this last summer. So to answer quickly, Firstly, you will test the living people and the one that accept to be tested, because some of them won't accept. And I think the first thing is to see them and look for livedo and perform an anamnesis to look for strokes and any arthralgia. And then I will check CRP, protein electrophoresis. And if you have any suspicion of the disease, then you can have the ADA2 measurement and the genetic testing by Sanger, because it's not so much money, Sanger sequencing. And then who will I treat? I will treat the ones that have severe symptoms. So of course, if you have chronic inflammation, like the first one, if you have amyloidosis, I will treat. One of the sisters, she had almost no features. So I spoke with her. I told her, well, we could begin TNF inhibitors because maybe one day you could make a stroke, but then you have the bad effects of TNF inhibitors. So she decided firstly not to have the treatment. So it's always a discussion of the benefits and the risk of each treatment. So it's not an obligation to treat them. And it's not an obligation to test everybody, because some of them they will not.
Thank you so much.
Thank you.